models that help us to understand what's going on within the cranial cavity itself. Now, the first model I've got here is a real skull, and what's interesting is if you run your fingers along the inside of it, on the side of the skull here, you can actually feel little grooves in the side of the skull, and these grooves are where arteries ran in life. So I can see a groove here, for example, and in life the middle meningeal artery would be running within this groove. And the middle meningeal artery is supplying blood to the meninges, but it's outside of the dura, it's extradural, but under the bone of the skull. Now, the most common cause of intracranial hematoma is subdural, but it's interesting to look at these extradural ones because they can come on very quickly and require our very best powers of observation to detect them. And if we look at this skull here, someone has put in some meningeal arteries for us. So here we have the middle meningeal artery. There is a posterior and an anterior meningeal artery, but we can see that the middle meningeal artery is dividing into a posterior and an anterior branch. And this is taking blood around the side of the head, going over the temporal bones and the parietal bones. And I think you can probably see from this that if there were to be a fracture of the skull involving the side of the skull on the temporal or parietal bones, then that irregularity in the skull could easily tear apart or cut into the middle meningeal artery. And that's the most common cause of extradural or epidural hematoma, that there is a skull fracture complicating and breaking or cutting into the middle meningeal artery, causing bleeding. And because this is an artery, it tends to bleed rapidly and it bleeds under high pressure. And the typical presentation here is that the patient is very often knocked out but recovers fairly quickly. The fact that they're knocked out means they've had a significant blow, often to the side of the head. Then very often the patient wakes up, there's a lucid interval, and the patient can be talking to you during that time. But then, as this artery carries on bleeding and the hematoma expands, initially you'll remember that there's compensation as cerebrospinal fluid moves down into the dural sac. But after that, the intracranial pressure will rise rapidly. And what you find with extradural hematomas is very often you have this lucid interval followed by a very sudden reduction in the Glasgow Coma Scale. So one reason to be very vigilant with your Glasgow Coma Scale observations is the possibility of extradural hematoma, blood leaking from the middle meningeal artery, particularly likely to be associated with fractures to the side of the skull. Now, the next model I want to show you is a brain here. This is looking at it from the bottom, and here we see the cerebrum, the temporal lobes here, the cerebellum, and of course the brain stem, midbrain, pons in this area here, and the medulla oblongata at the bottom. And one thing I particularly want to notice in this diagram is the white lines on this diagram represent the cranial nerves. Now, you probably remember that there's two types of nerves communicate between the brain and the body. There are the 31 pairs of spinal nerves communicating between the spinal cord and the body, but also there's 12 pairs of cranial nerves as well. And the cranial nerves communicate between the brain and the body without going via the spinal cord. And very often these are things in the head and the neck where it will be pointless to go via the spinal cord. It's much better to have a local nerve route. And these are the cranial nerves. And there's 12 pairs. So these first pairs here are the nerves of smell, the sense of olfaction, the olfactory nerves. And actually, if we look at the skull here, try to think of this upside down inside this cranial cavity. But I don't know if we can see here, if we can get into that. There's a lot of small bones there, a lot of small holes rather in these bones. And this is where branches of the olfactory nerve go through into the top of the nose. So the smell detector's in the top of the nose. These nerves go through these little small perforations here and into the first cranial nerves, the olfactory nerves. And so we see these nerves here going back towards the lobe and the temporal bone. The second pair of cranial nerves after the olfactory are the optic. And here we see the branches of the optic nerve. And of course, in life, they go forward because they're carrying information back from the retina. And then the nerve I want to tell you a little bit more about, olfactory, optic. The third one here is the oculomotor. Now, this blob here is the pituitary gland, which is somewhat in the way. But I think you can see there's a white blob, two white blobs in there. That is the root of the pair of oculomotor nerves. And the oculomotor nerves, as you can see, are arising in the midbrain, and they are going forward to the internal and external eye muscles. Now the other cranial nerves, 1, 2, 3, and they go back 4, 5, 6, 7, 8, 9, 10, 11, 12 as it goes further down towards the spinal cord into the medulla oblongata. So the 12 pairs of cranial nerves. Start numbering at the anterior part of the brain, going back the way. But we're only going as far as the third one today. And actually, while I've got this model, if it doesn't fall apart, I think I'll try and show it to you. This is about the actual size of a human brain. And I think we can see the sulci and gyri of the cerebral cortex to scale on this model. The gyri with the sulci in between. Frontal lobes. This is the area of the central sulcus. Precentral gyrus, postcentral gyrus. Precentral gyrus, of course, is motor. Postcentral gyrus is sensory. Here we can see the temporal lobes, frontal lobes, parietal lobes, and of course at the back the occipital lobes. And underneath we've got the frontal lobes, temporal lobes, and as we've already looked at, the brainstem and cerebellum. Now, why is it so important to know about the oculomotor nerve when we're considering head injuries? Well, here we have another skull, and of course, as we can see in life, the skull is a closed and a rigid vault. Swelling inside the skull cannot cause swelling of the skull. It can only increase the pressure within the cranial cavity. The holes at the bottom are filled with nerves, blood vessels, and connective tissues during life. Now, I've got some interesting anatomy I'm going to try and show you inside here. So let's take off this, the top of this skull. And what I've done here, well, first of all, we can see the anterior, middle, and posterior cranial fossa. The frontal lobes in life lie in here. And we can see that in the middle cranial fossa, that's all nicely sculpted out to fit the lobe, the temporal lobes. And the posterior cranial fossa here, we can see these large hemispheres of indentation in the skull, which of course in life house the cerebellum. The foramen magnum here for the spinal cord to be continuous with the medulla oblongata. So in life we have the frontal lobes here, the temporal lobes here, and the cerebellum here. And of course the brainstem is roughly in the position where my thumb is now because it's consistent with the spinal cord. And the hemispheres of the cerebellum in the back here. Now, as we've looked at before, the dura mater lines the inside of the skull, but it also forms a fold inwards here roughly in the position of this piece of red card. So the tentorium is an infold of dura, roughly in that position. Now actually the real tentorium, the infold of the dura, is pointed in the middle. It goes up to a single point. Because the tentorium looks like an old-fashioned tent, that's why it's called the tentorium. It is the tent of the cerebral, of the intracranial cavity, of the cranial cavity. So that's the position of the tentorium, slightly folded up. So above the tentorium we have the cerebrum. Below the tentorium we have the parts of the brain stem and the cerebellum. Now this is fine when the pressure here is normal. But if there's increasing pressure from a supratentorial lesion, then there's increasing pressure down on the tentorium. So a supratentorial space-occupying lesion is going to cause downward pressure on the tentorium. And one reason that we do observations of the pupil, well, the main reason we do observation of the pupil, is that the oculomotor nerve is going in to supply the eye muscles. So the oculomotor nerve in life is roughly in this position. Remember, it's arising in the midbrain. And the fibres that control the pupil, the fibres that control the diameter of the pupil, are on the outside. They are towards the periphery of the oculomotor nerve. So if there's downward pressure, you can actually see there's quite a sharp ridge there of bone, part of the temporal bone. So pressure down the way on this side can start to compress the oculomotor nerve. So you can see the oculomotor nerve is now compressed as a result of pressure. And because the fibres that control the pupil are on the outside of the oculomotor nerve, these will be affected first. And the pupil will become sluggish, and eventually it will become fixed and dilated. And in addition to that, if there's a lot of pressure above the level of the tentorium, then part of the temporal lobe can be pushed down and it can herniate, roughly where my finger is now, it can herniate into the infratentorial cavity. Now this area here is called the tentorial notch. It is the area, well, there's the temporal bone there and the tentorium behind. So the tentorial notch is this gap in the tentorial membrane. And if there's very high pressure from above, part of the temporal lobe can be pushed down into the infratentorial space. That's called tentorial herniation. And as we can see, the tentorial herniation is compressing the oculomotor nerve. And that will result in the pupils not reacting to light and becoming fixed and becoming dilated.